Today, in What's New in 22Q, we are embarking on, well, an essential and incredibly detailed deep dive. Our mission today is really to distill the essential, practical, and supportive knowledge from a huge new set of international clinical practice guidelines.
hmm
These guidelines are effectively the modern roadmap for the comprehensive care of children and adolescents living with 22q11.2 deletion syndrome.
It really is a monumental piece of work, and it's something we know our listeners, parents, caregivers, families have been waiting for.
Yeah.
Because with a complex multi-system condition like 22q11.2DS,
Mhm.
well, families often feel like they're juggling care across, a dozen specialties, always trying to anticipate the next challenge.
Absolutely. And that's the beauty, isn't it? Having these rigorous consensus-based guidelines, it sort of lifts that burden of information overload off the family.
Exactly.
It gives a standardized structure so that, every specialist, wherever they are, is working from the same page, ensuring that coordinated, comprehensive care.
It shifts care from just reacting to being proactive.
Proactive, yes,
Yeah.
that's the key word.
And that proactive focus is critical because today, we're specifically zooming in on those foundational years,
Right.
the entire pediatric lifespan, from birth right up through that really crucial transition period leading to age 18.
That period really sets the stage for everything that follows.
Like us.
We did previously discuss the separate guidelines for adults with 22q11.2DS in another deep dive. So this one really completes the picture, giving us that framework for the vital early years. So to frame our discussion, let's start with the source material itself. Who actually put this incredible document together, and what does it represent?
Okay, so we're focusing mainly on the paper detailing the updated recommendations for optimal care for children and adolescents with 22q11.2DS. It was led by Solveig Oscarsdottir, and it represents a massive, truly collaborative effort.
An international effort.
Absolutely, an international consortium of experts. We're talking 24 subspecialties across 9 different countries.
Yeah.
It's huge.
Wow, that really is the definition of consensus then.
It absolutely is. And this work, which came out around 2022, it didn't just appear out of nowhere.
Right, built on previous work.
Exactly. It's systematically reviewed, thousands of reports published over the last decade or so. And it built upon the original guidelines from back in 2011. The goal was clear. Update protocols, incorporate the best new practices, and address areas where research gave us more clarity, really making sure the care framework is state-of-the-art.
Okay, that's a solid foundation. Let's maybe unpack this by first giving a sort of plain English summary of the condition itself.
Good idea.
We can't really talk about comprehensive guidelines without understanding the complexity they're designed to manage. So what exactly is 22q11.2DS?
Well, in short, it's the single most common microdeletion syndrome that we know of.
The most common, really?
Yes. The prevalence is often quoted around 1 in 2,148 live births. Some figures say closer to 1 in 4,000, but either way, it's much more common than many people realize. And the cause is the loss, the deletion, of one copy of a very specific small segment of genetic material.
On chromosome 22.
Exactly. A region on chromosome 22, hence the name 22q11.22. Most commonly, it's what we call the 2.54 millibit deletion. LCR22A to LCR22D for the technical folks.
So it's not like the whole chromosome is missing, just a tiny piece.
Precisely. That's why it's called a microdeletion. But, and this is critical, that small missing piece contains somewhere between 30 and 40 genes.
Ah, okay.
Those genes. They're involved in building and regulating multiple body systems, which is why 22q11.2DS is fundamentally a multi-system disorder.
And it's highly variable, right? I hear that a lot.
Extremely variable. And that's such a critical point for families. The severity can be dramatically different, even between people in the same family who have the exact same deletion.
I can only imagine how confusing that variability must be for parents just trying to get consistent information.
It really can be.
So if it affects multiple systems, what are the main issues that usually bring a child to medical attention early on?
Well, the phenotype, the range of features is incredibly broad. Physical, cognitive, behavioral elements, they're all potentially involved. But the earliest, most acute warning signs often involve the systems that are most complex structurally.
Like the heart.
Exactly. Congenital heart defects are very common, and they're the most critical initial concern. We also frequently see severe feeding difficulties, low calcium levels, that's hypocalcemia, and issues with the immune system.
And the guidelines address all of these.
Yes, absolutely. They stress how important early diagnosis is to manage these risks proactively from the start.
So given all this complexity, what's the underlying philosophy of care that emerges from these guidelines? How should parents and professionals approach managing it?
The consensus is crystal clear. Care absolutely must be coordinated and multidisciplinary.
Not just one doctor.
No way. This syndrome cannot be managed effectively by a single pediatrician alone. It requires specialists, cardiologists, immunologists, endocrinologists, speech therapists, mental health professionals. The list goes on.
All working together.
And communicating seamlessly. That's the key. The central goal, you see it repeated throughout the guidelines, is preventive management.
Catching things early.
Yes. Periodic assessment to catch those anticipated features early. And always, always focusing on the family unit, supporting the child to optimize their quality of life and reach their full potential.
That's a very positive and, well, comforting frame. Okay, let's dive into the practical application of these guidelines, starting right at the beginning of the journey. Genetics.
Genetics is absolutely fundamental. It answers that crucial question about inheritance and recurrence risk,
Oh.
often one of the first things a new parent asks.
Right. So let's talk about the key do's for families regarding genetic testing. If a child gets diagnosed, what's the absolute next step, according to these guidelines?
The primary directive is very clear. Parental testing must be performed, period.
Even if the parents seem perfectly healthy?
Even then. Now, the vast majority, over 90% of cases with that typical 2.54 millimeter deletion are de novo,
Meaning new.
meaning the deletion is new in the child. It wasn't inherited because it's not present in either parent's blood cells.
Okay, but that still leaves up to 10% where it is inherited. What does that imply for the family?
That 10%, well, it's absolutely vital information. If one parent does carry the deletion, the recurrence risk for any future pregnancy jumps to 50%.
50%, that's huge.
It's a life-changing number. And crucially, the guidelines really emphasize you cannot assume a parent is clinically unaffected just because they don't have severe, obvious symptoms.
Ah, okay. So a parent could have it mildly.
Very mildly, yes. Some parents might just have a subtle learning difference or maybe a slight palatal anomaly they never even knew about. They might be completely unaware they carry the deletion until their child is diagnosed.
That's incredibly important counsel. So the message is, do not skip parental testing just because the parents appear healthy,
Exactly right. And we should also mention the rare possibility of mosaicism.
where it's only in some cells.
Correct. Where the deletion is present in some cells but not others, or perhaps only in the germline, the sperm or egg cells. Even in those rare cases, the recurrence risk is higher than for the general population.
So genetic counseling is key.
Absolutely. Genetic counseling and appropriate testing are needed across the lifespan for the whole family unit.
Okay, let's quickly clarify the testing itself. For diagnosis, we hear terms like FISH, karyotype, CMA. Which one is the go-to now?
For the initial diagnosis in the child, chromosomal microarray, or CMA, is definitely the preferred standard today.
Why is that?
It's highly sensitive and very accurate for identifying the specific size and location of the deletion. A routine karyotype, well, it's just not sensitive enough. That missing piece, the 2.54 malabine, is simply too small to be reliably seen with the traditional microscope setup.
And FISH.
FISH analysis, which is more targeted, is still very useful, particularly for checking relatives of someone already known to have the deletion.
Now, here's where it gets really interesting, touching on that complexity again. You mentioned 22q is complex, but sometimes the symptoms are really atypical, right? Things that don't seem to fit the usual picture. Why does that happen, and what should doctors look for?
Yes, this is a really important, nuanced area, and it highlights a fascinating diagnostic challenge. The guideline here is never ignore atypical clinical findings.
Don't just assume it's part of the 22q variability.
Exactly. Sometimes the 22q11.2 deletion, which remember wiped out one copy of 3040 genes, might inadvertently unmask a second, completely separate recessive condition.
Unmask. How does that work?
Think of it like a double hit. The child lost one copy of a gene because it was in the deleted 22q region, and then the other copy, the one they still have on the intact chromosome 22, happens to have its own independent pathogenic variant or mutation.
Wow. So the deletion reveals a problem on the other chromosome.
Precisely. The deletion takes away the backup copy, revealing the underlying recessive disorder that wouldn't have otherwise shown up.
Can you give us an example of what that might look like in practice?
Sure. The guidelines specifically mention a couple of examples. One is TANG2-related disorder. This can cause severe metabolic crises, arrhythmias, muscle breakdown, really serious stuff.
Okay.
Another example is Bernard-Soulier syndrome, which is a severe bleeding disorder. So if a child with 22q presents with, say, unexplained recurrent metabolic problems or really severe bruising or bleeding, that just doesn't fit the typical 22q picture.
Then you need to dig deeper.
Yes. The guidelines recommend considering more specialized testing in those cases, maybe targeted gene sequencing or even whole exome sequencing to check those remaining genes on the intact chromosome for a hidden secondary condition. It ensures we're treating all the child's genetic risks, not just the 22q deletion.
That's a phenomenal level of detail, a huge clinical pearl for care coordinators. Okay, let's move straight into health monitoring, starting with probably the biggest acute risk factor, cardiology, the heart.
Cardiology is absolutely non-negotiable. It requires vigilance, really, throughout life. Congenital heart disease, CHD, affects about 2/3 of children with 22q.
2/3, that's a lot.
It is. And sadly, it remains the leading cause of mortality in this population, especially in infancy, which is why early diagnosis and intervention are so incredibly critical.
What are the most common types of heart defects we should be aware of?
We're mainly talking about what are called contratruncal defects. These affect the large blood vessels leaving the heart and the outflow tracts.
Okay.
The big three are usually considered tetralogy of Fallot, often called TOF, truncus arteriosus, and then one that's particularly critical for diagnosis, interrupted aortic arch type B, or IAAB.
Why is that one IAAB so critical for diagnosis specifically?
Because the association between IAAB and 22q11.2 deletion is incredibly strong. So strong, in fact, that the guidelines state very clearly, finding IAAB should always prompt an investigation for the 22q deletion.
Even if there are no other obvious signs?
Even then, the two just go hand in hand so frequently.
Now, many children with 22q have life-saving heart surgery very early on. If that surgery is successful, can families sort of breathe a sigh of relief, or does cardiac monitoring need to continue?
That's such a vital question, and the answer is unequivocal.
Yeah.
The surveillance absolutely must continue. Indefinitely.
Lifelong.
Lifelong. Even after successful surgery, long-term follow-up is mandatory. This often means transitioning care to specialized adult clinics, sometimes called grown-up congenital heart disease or GUCH clinics.
Okay.
But here's where it gets really interesting and where these updated guidelines brought a sharper focus, something quite new.
Oh, tell me more.
Well, it turns out that even children who were initially thought to have completely healthy hearts, those without a diagnosed CHD at birth, still need periodic cardiac surveillance.
Really? Why is that?
Because we've seen reports, and the evidence is growing, of later onset issues emerging. Specifically, things like dilated aortic root, that's an enlargement of the aorta where it leaves the heart, and also arrhythmias or irregular heart rhythms.
And these can appear later, even if the heart looked normal initially.
Yes, they can emerge later in childhood or adolescence.
Yeah.
These are risks that seem to exist even in a structurally normal heart in someone with 22q.
So the practical takeaway is,
Periodic screening for both aortic root dilation and arrhythmias is now recommended for all patients throughout childhood and adolescence, regardless of whether they had CHD diagnosed at birth. It's a critical preventive measure.
that definitely shifts the focus, doesn't it? From just repairing an initial defect to managing a lifelong predisposition. Okay, let's move to the immune system. Another area defined by, well, that word again, variability.
Variability is absolutely the core concept here. About 80% of infants with 22q start out with diminished T-cell numbers. This is often linked to an underdeveloped or hypoplastic thymus gland.
Right, the thymus is key for T cells.
It is. Now, the good news is that for most children, the immune system compensates over time, and those T-cell numbers often improve as they grow older.
But they're not always.
Not always. And that's why the guidelines stress. You must presume immune compromise until a thorough evaluation is complete. Don't assume anything.
Okay, so what's the most immediate, critical, practical implication of that for parents and caregivers? Where does it matter most day to day?
It centers almost entirely on vaccinations, specifically the live viral vaccines,
Like MMR.
like the measles, mumps, rubella MMR vaccine, yes, or the varicella chickenpox vaccine. The mandate here is crystal clear. You absolutely must check the immune status before giving any live vaccines.
How do they check that?
It involves specific blood tests, looking at T-cell counts, particularly CD4 cells, looking at B-cell subsets, and checking antibody responses to previous vaccines.
And what are the cutoffs? When is a live vaccine considered too risky?
If the T-cell counts are severely low, the guidelines give a specific threshold. If the CD4 T-cell count is below 400 cells per cubic millimeter, then you must not administer live viral vaccines. It's too dangerous.
But if the immune function looks okay,
Then all the standard non-live vaccines, like the flu shot, tetanus, pertussis, all of those, are highly recommended and should be given right on schedule.
okay.
And one other point. for very young infants who might need a blood transfusion before their immune status is fully known.
Yes.
Any blood products they receive must be irradiated first. This prevents a rare but potentially fatal complication called transfusion-associated graft versus host disease. Standard procedure in this situation.
Got it. Now, beyond infections, we often hear about a dramatically increased risk for autoimmune conditions in 22q. What should families be watching for there?
Yes, vigilance is really key for autoimmune issues. The risk is substantially increased compared to the general population.
How much increased?
Well, for example, the risk for juvenile idiopathic arthritis, JIA, that's a painful inflammatory joint condition, is estimated to be maybe 20 times higher.
20 times.
And even more dramatically, for idiopathic thrombocytopenic purpura, or ITP, that's a bleeding disorder caused by the immune system attacking platelets, the risk is reported to be up to 200 times more common.
Wow. So what are the red flags parents should look out for?
Things like persistent, unexplained joint pain or swelling,
Mm.
or chronic bruising, easy bleeding, little pinpoint red spots on the skin, called petechia. These could be red flags requiring immediate investigation by their doctor.
Okay, that's crucial awareness. Let's turn now to hypocalcemia. Those low calcium levels often linked with the classic DiGeorge features of the syndrome. This is common and potentially dangerous, especially in newborns, right?
It absolutely is. Hypocalcemia affects a pretty large percentage of children, with 22q estimates range from maybe 17% up to 60%. It often stems from hypoparathyroidism, where the parathyroid glands, which regulate calcium, are underdeveloped or sometimes even absent.
And in newborns, the first sign can be serious.
Yes, often the first sign in the neonatal period is seizures. So rapid diagnosis and intervention are essential.
Does this risk of low calcium just go away as the child gets older?
Rarely, completely. While calcium levels often stabilize during calm periods in childhood, the risk of hypocalcemia recurring is really lifelong.
What can trigger it later on?
It can be triggered by periods of significant physiological stress, things like an acute illness, any major surgery, whether it's cardiac surgery or something else. Puberty is a known stressor, and even pregnancy later in life.
So vigilance needs to be ongoing.
Absolutely, which is why routine monitoring is so crucial.
What does that monitoring look like in practice for families?
In infancy, it's pretty frequent. Checking calcium levels, along with parathyroid hormone, PTH, and magnesium, maybe every 3 to 6 months is standard.
And then less often later.
Yes, as the child stabilizes, this usually shifts to annual or maybe biannual checks in older childhood. However, and this is the big one, there's a mandatory requirement to check calcium levels both before and after any surgical procedure.
Any surgery, even minor ones.
Any surgery, no matter how minor it seems.
Yeah.
Because that stress can rapidly deplete the body's available calcium.
Okay. Now, you mentioned before there's a really specific and maybe counterintuitive recommendation in the guidelines about not overtreating hypocalcemia. If calcium is low, why wouldn't we want to get it right up into the high normal range?
Yes, this is possibly one of the most important subtleties in the entire medical management section, and it really shows the complexity of managing a multi-system disorder. The goal of calcium management in 22q is generally to maintain the levels in the low normal range, not the high normal range.
Low normal. Okay, why is that distinction so critical? What's the danger if the levels get pushed too high?
Well, if you overtreat maybe with too much calcium supplement or too much activated vitamin D like calcitriol, and you push those calcium levels consistently too high, it leads to something called hypercalciuria.
Too much calcium in the urine.
Exactly. Excess calcium gets excreted in the urine. And over time, that excess calcium can precipitate out in the kidneys, forming calcium deposits or stones. It's called nephrocalcinosis.
And that damages the kidneys.
It can lead to serious long-term kidney damage. So we're constantly balancing the immediate risk of low calcium symptoms, like seizures, against the long-term risk of damaging the kidneys with the treatment.
So managing the calcium carefully to protect the kidneys, that sounds like it requires even more monitoring then.
It does. If a patient needs long-term calcium or calcitriol supplements, the guidelines insist on additional surveillance. This means monitoring how much calcium is actually being excreted in the urine and doing intermittent kidney ultrasounds to check for early signs of nephrocalcinosis.
Making sure the cure isn't causing another problem.
Precisely. We need to ensure the treatment for the low calcium isn't unintentionally harming the kidneys. And just separately from that specific therapy, routine vitamin D supplementation is generally recommended for all patients anyway, just to support overall bone health and endocrine function.
That distinction, low normal versus high normal for calcium, is absolutely vital. It really underscores why having these detailed expert guidelines is so important. Okay, let's transition now into our third major section, development, learning, and emotional well-being. These are often the primary concerns for families once the really acute medical issues are stabilized.
Yes, absolutely. These areas really define the day-to-day life of the child and the family, starting with speech, hearing, and airway. We see palatal issues, what's often called velopharyngeal dysfunction, or VPD, affecting about two-thirds of children.
Two-thirds again. So what does VPD actually look like or sound like to a parent?
Well, VPD essentially means that the soft palate at the back of the mouth and the walls of the throat, the pharynx, can't close off the nasal cavity properly during speech.
Okay.
This lets air escape through the nose when they talk, leading to hypernasal speech. The child might sound muffled or just really difficult to understand.
Does it affect anything else?
Yes, and it very often impacts feeding too, especially in infancy. It can cause nasal regurgitation where milk or food comes back out through the nose during swallowing.
So when should assessment for these issues begin, and how do we address the speech delay that often comes with it?
Assessment needs to start early and be ongoing. The guidelines say you must evaluate speech and language skills routinely, starting somewhere between 6 and 18 months of age, and then regularly after that.
And what kind of speech issues are most common?
It's very common to see a gap where the child understands language quite well, that's receptive language, but they really struggle to produce speech themselves. Those are expressive language deficits.
Right. So given that expressive delay, what's the consensus recommend for early intervention strategies?
The consensus definitely leans towards being proactive with support. A major practical recommendation is to consider using augmentative and alternative communication AAC strategies early on,
Like sign language.
like sign language, yes, or picture exchange systems. The goal is to promote overall communication skills and, really importantly, reduce the frustration that builds up when a child understands their world but just can't express their needs or ideas effectively.
Now that often raises a concern for parents, doesn't it? Will using something like sign language actually delay their child starting to talk?
It's a very common worry, completely understandable. But the evidence we have is actually quite reassuring. The guidelines specifically emphasize you should not assume that using AAC will delay verbal speech development.
It might even help.
In many cases, it seems to act as a bridge. It takes the pressure off verbal production and helps develop the underlying cognitive pathways needed for all forms of language and communication.
Okay, that's good to know. Now, closely related to speech is hearing. Hearing loss must impact language development too, right?
Precisely. They're intimately linked. And hearing loss is frequent in 22q. It's often conductive hearing loss, which is caused by recurrent or chronic middle ear infections. Otitis media with effusion, the technical term. Glue ear.
Why are ear infections so common?
Well, those same palatal issues that affect speech often cause problems with the eustachian tube function, the tube that connects the middle ear to the back of the throat. If it doesn't work properly, fluid builds up behind the eardrum, leading to infections and hearing loss.
So what's the recommended intervention strategy for that?
Again, it's proactive intervention to optimize hearing as much as possible. The guidelines say you must perform periodic ear exams and formal audiology evaluations. And, importantly, there should be a very low threshold for placing myringotomy tubes, commonly just called ear tubes.
To drain the fluid.
Exactly, to drain the fluid and ventilate the middle ear. Optimizing hearing acuity is just non-negotiable if you want to support speech development and later academic success.
Makes sense. Okay, one last point on this section. The airway itself, particularly thinking about surgery for those palatal issues, the VPD.
Yes, airway safety remains absolutely paramount throughout. We know that sleep disorders, especially obstructive sleep apnea, or OSA, are an inherent risk in 22q anyway.
Okay.
But perhaps surprisingly, this risk of OSA can actually increase after certain surgeries to correct VPD, like a pharyngeal flap surgery.
Why would surgery make it worse?
Because the goal of that surgery is often to intentionally narrow the space in the pharynx to help speech closure. But narrowing that space can sometimes compromise the airway during sleep.
Ah, I see.
So the recommendation is clear. You must monitor sleep quality closely and strongly consider ordering a formal sleep study that's a polysomnography, both before and after any VPD repair surgery, just to ensure the airway remains safe during sleep.
Right, balancing speech improvement with airway safety. Okay, Let's transition now to the complex neurocognitive profile, often seen in 22q11.2DS, focusing on how this impacts learning and education.
Yes, the cognitive profile is definitely a hallmark of the syndrome. Perhaps the most distinct feature is a common discrepancy between verbal skills and nonverbal or performance skills.
What does that mean exactly?
It means that typically verbal IQ scores tend to be higher than performance IQ scores, sometimes by quite a significant margin. This pattern strongly suggests what's often called a nonverbal learning disability profile.
Okay. And practically speaking, what does that look like for a child trying to learn in a classroom?
Well, it means they might actually be relatively strong in areas that rely heavily on language. Things like rote memory, learning facts, reading, decoding, sounding out words, and maybe spelling. Skills based on verbal processing.
But they struggle elsewhere.
Yes, they often struggle intensely with tasks that require visual spatial perception, understanding maps or diagrams, fine motor coordination like handwriting, organization skills, planning, and notoriously, mathematics.
Math is a big one.
Math difficulties are almost universal and often quite profound. So even if a child has an overall IQ score that falls within the normal range, this specific profile almost guarantees they will face significant learning challenges.
When should this kind of complexity be formally assessed to help with school planning?
The guidelines are firm here. You must encourage formal, comprehensive neuropsychological testing. This is really vital because a child's needs change as the demands of their environment increase.
Especially at transition points.
Exactly. It's particularly critical around those major transition points, like moving from primary to secondary school, when the academic workload, the need for organization, and the social complexity just skyrocket.
And the testing helps pinpoint strengths and weaknesses.
Yes, the testing helps identify those specific relative strengths, like maybe good rote memory, that educators can leverage, while also clearly pinpointing the core areas of deficit that need targeted support.
So interventions should really target those specific weaknesses, like executive function or math.
Precisely. Individualized education plans, or IEPs, should focus interventions squarely on areas like executive function planning, organizing, managing time, visual spatial skills, and math remediation. But the guidelines also offer a really crucial philosophical point here, a warning almost,
Which is?
which is you must not treat an intelligence test IQ score as some kind of static fixed constant or as a complete picture of the child's abilities.
That's a powerful statement. Why the warning against relying too heavily on just that IQ number?
It's because we often see that intellectual capacity and functional skills can appear to plateau or sometimes even seem to decline relative to peers over time.
Not because the brain is actually deteriorating.
No, usually not. It's more often because the gap widens between the child's relatively stable cognitive capacity and the rapidly increasing complexity of their environment. Harder schoolwork, higher social expectations, demands for more independence.
The world gets harder faster than they can keep up.
Exactly. So, flexibility and support and continuous monitoring of the fit between the child's abilities and their environmental demands are absolutely crucial to prevent overload, chronic stress, and potentially stress-related behavioral issues.
That makes perfect sense. The environment matters hugely.
Yeah.
Okay, now let's address what is often the most significant long-term risk that families worry about. Psychiatric health, especially during adolescence and the transition to adulthood. We should probably spend a good bit of time here.
Yes, this section of the guidelines really demands a compassionate but extremely proactive approach from everyone involved. Neurodevelopmental differences often begin quite early.
Like ADHD and autism.
Yes, attention deficit hyperactivity disorder, or ADHD, most commonly the inattentive type rather than hyperactive, affects maybe up to 40% of children with 22q. And autism spectrum disorder, ASD, is also highly prevalent, seen in perhaps up to 30%.
Those numbers are significantly higher than in the general population. But the risk that gets talked about most, the most severe risk associated with 22q, is the risk of psychotic illness, correct?
It is. 22q11.2DS is currently considered the highest known genetic risk factor for developing psychotic disorders later in life.
The highest genetic risk factor.
Yes. The risk for developing a psychotic illness, most commonly schizophrenia or schizoaffective disorder, increases dramatically during those transition years, late adolescence and early adulthood. It potentially affects up to 25% to 30% of adults with the deletion.
25 to 30%. That is an absolutely staggering lifetime risk. How do we translate that knowledge into practical action for parents who have a child entering adolescence? What kind of screening should be happening?
Proactive screening is completely non-negotiable. Pediatricians, family doctors, mental health professionals, they should all be regularly screening for what we call subclinical or prodromal symptoms.
What does that mean for a parent, practically? What should they be vigilant for?
For a parent, it means being alert for subtle but persistent and concerning changes in their child's thinking, their emotions, or their behavior. Changes that stick around for weeks or months, not just a bad day or two.
Can you elaborate a bit on what those subtle changes might actually look like? It's probably not like what you see in movies initially.
No, exactly. Initially, it often isn't a sudden, dramatic break from reality. It might manifest more as increasing social withdrawal, maybe becoming much more isolated, or severe disorganization, difficulty managing daily tasks, or maybe pervasive problems concentrating that seem much worse than typical teenage distractibility.
Any other signs?
The young person might start expressing unusual or unrealistic beliefs that seem odd or out of character. They might report strange perceptual experiences, maybe hearing whispers or indistinct voices when no one is there, or seeing shadows or distortions in their vision.
So if you notice a pattern,
Yes, if you notice a persistent pattern of change, if they start making strange connections between unrelated events, maybe become suspicious or paranoid, suddenly start talking about being watched or conspiracies, these are potential red flags that absolutely require expert assessment.
so the focus has to be on early detection and getting help quickly.
Absolutely. The recommendation is unequivocal. If thinking, emotions, or behavior change significantly and persistently, you must refer immediately to a specialist, usually a psychiatrist or psychologist experienced with psychosis risk, for a thorough assessment.
And early intervention helps.
Massively. Early diagnosis and intervention for emerging psychotic illness or severe mood disorders significantly improve the long-term prognosis and quality of life. It makes a huge difference.
Okay. Are there any preventative steps that families can realistically take to try and mitigate this substantial risk, knowing the genetic predisposition is there?
That's the key question, isn't it? While we obviously can't change the underlying genetic predisposition, we can try to control or modify environmental triggers and vulnerabilities that might interact with that risk. The guidelines strongly advise focusing risk reduction efforts on two main things. First, doing everything possible to decrease overall stress levels, and second, strongly discouraging the early use of substances.
Okay, let's talk about the substance use part. That seems critical.
It really is. Alcohol, and especially recreational drugs with a particular focus on marijuana or cannabis, are known to significantly elevate psychiatric risk, particularly psychosis risk, in individuals who are already genetically vulnerable.
So given the very high baseline risk in 22q,
Early or chronic use of these substances absolutely must be strongly discouraged. It's a major modifiable risk factor.
what about other things, like anxiety?
Yes, anxiety disorders are also extremely common, maybe affecting around 35% or so. And the guidelines make a specific note that high caffeine intake can significantly worsen anxiety symptoms. So, limiting or avoiding caffeine is another simple, practical step families can take.
So it's about managing stress, sleep routines, avoiding substances.
Exactly. Managing stress, promoting good sleep hygiene, focusing on stable routines, encouraging healthy coping mechanisms. These are all part of the essential preventive mental health toolkit for adolescents with 22q.
That strong emphasis on prevention and early vigilant monitoring really underscores how seriously this aspect of care needs to be taken. Okay, let's move now to our final major topic, the transition from pediatric to adult care, those pivotal years, say, from age 13 up to 18 and beyond.
Yes, this is perhaps one of the most vulnerable periods and, frankly, one that's often overlooked or poorly managed. A key point is that youth with 22q11.2DS generally exhibit greater developmental immaturity compared to their peers without the deletion.
So even if they're 18 chronologically.
They often require significant ongoing support from their parents or caregivers, often well into their 20s or even later, particularly around complex decision-making, finances, and daily living skills.
So the transition can't just be an abrupt handoff when they turn 18. It needs to be a planned, proactive, systematic process, right?
Absolutely. It needs to start much earlier. The guidelines suggest the process should really begin around age 13 or 14.
What are the essential steps?
You must prepare the adolescent in a stepwise manner. This means focusing on both increasing their health independence and addressing social issues. You start gradually shifting responsibility for things like knowing their medications, making appointments, communicating with doctors, all under supervision initially, of course.
And what about actually finding and establishing the adult medical team?
That's crucial and needs planning well in advance. You must identify and start communicating with appropriate adult practitioners before the transition happens. This includes finding a good general practitioner or internal medicine doctor who is willing and able to coordinate the complex, multi-system care.
And the specialists.
And identifying the relevant adult specialists, they'll need like an adult congenital cardiologist, an adult psychiatrist, endocrinologist, etc. Ideally, if it's available, this involves a formal referral process to a specialized adult 22q clinic.
And I assume this needs to happen even if the young person seems relatively healthy at age 18. They still need that adult follow-up established.
Absolutely, yes. The guidelines are very clear on this.
Yeah.
All patients must be referred for continued adult follow-up, regardless of how healthy they appear at the point of transition.
Why is that so important?
Because we know that features of the syndrome like those later onset cardiac issues, autoimmune problems, and especially the psychiatric risks can emerge or change significantly across the adult lifespan. A person is never really discharged from needing appropriate surveillance for 22q-related issues.
Okay. Now, beyond the medical transition, there are also significant legal and financial preparations that families need to think about before the child turns 18.
Yes, this is non-negotiable, particularly for individuals who, due to maybe mild or moderate intellectual disability or significant executive function challenges, are likely to require ongoing support to manage their affairs.
What kind of preparations?
Guardianship planning, potentially establishing special needs trusts, and preparing wills. These things absolutely must be considered and ideally established before the individual reaches the age of majority, which is 18 in most places.
And why the urgency? Why before 18?
Because the moment they turn 18, legally they become an adult. And at that point, parents automatically lose the legal authority to make critical decisions about their finances or medical care unless guardianship is in place.
Which could cause huge problems.
Huge problems. Without guardianship or other appropriate legal structures like special needs trusts, the individual might lose eligibility for crucial government benefits like supplemental security income, SSI, or disability support. Or they might be unable to consent to necessary medical treatment or be vulnerable to financial exploitation. This pre-planning is essential to secure their future financial and medical well-being.
Makes sense. Okay, finally, let's just quickly revisit the social vulnerability aspect during this transition phase.
Yes, this is a really sensitive area where ongoing parental guidance and support are often key. That neurocognitive profile we discussed, potential deficits in judgment, impulsivity, social reasoning, can unfortunately increase the risk of social vulnerability.
What kind of vulnerability?
This can include a higher risk of being bullied, including cyberbullying, and sadly, also increased risks of sexual exploitation or victimization due to difficulties reading social cues or asserting boundaries.
What practical steps can families take to try and mitigate these social risks proactively?
Well, the guidelines suggest you must monitor social media contacts and maybe limit unstructured screen time, especially early on. Instead, try to encourage participation in alternative, healthy, structured activities, things like sports, art classes, supervised social groups, which can help build more resilient social skills in safer environments.
And reproductive health.
And absolutely, comprehensive counseling on reproductive health is essential as they mature. Affected individuals need to fully understand that they themselves carry a 50% chance of passing the 22q11.2 deletion on with each pregnancy. This knowledge is a key part of empowering them to make informed decisions about their own futures and family planning.
Wow. We have certainly covered a huge amount of ground today, from the nuanced genetics of inheritance and unmasking recessive conditions to the specific medical risks in infancy, like heart defects and hypocalcemia, the lifelong surveillance needed for the heart, immune system, and calcium, and then all the critical proactive planning needed for educational support, mental health monitoring, and that complex transition to adulthood.
It's a lot, but the key message, I think, that comes through from these updated, incredibly comprehensive guidelines is really one of hope and action.
Hope and action. I like that.
Yes, because while 22q11.2DS clearly presents numerous potential challenges affecting almost every system in the body, these consensus recommendations provide families and clinicians with an incredibly detailed toolkit. They emphasize that through early diagnosis, through coordinated, precise, and proactive care, we really can significantly diminish the burden of the condition on patients and their families.
Knowledge truly is power here, isn't it? By having access to these evidence-based, internationally agreed-upon recommendations, we can better support every individual with 22q11.2DS in reaching their absolute fullest potential, making sure the necessary supports are always in place right when they're needed.
Exactly.
This deep dive is brought to you by 22q11 Europe, the European Association supporting families living with 22q11 deletion syndrome.
Thank you so much for joining us today and for taking the time to absorb all this vital information. Remember, the whole goal of this ongoing research and these guidelines is ultimately to make managing this complex condition clearer, more proactive, and more manageable for you and your family. We really hope this deep dive gives you some concrete, actionable points to discuss with your own care team.
Thank you for listening to What's New in 22q, produced by Dr. Stefan Elias for 22q11 Europe. Take care and talk to you soon.